Good afternoon. I think we're very lucky to have Adrian looking after us because this is an absolute minefield. And I'm here as my role on the Bowel Oncology Committee, just to show you the data sets we've put together. 2 years ago, when we started rearranging the data sets, it was with a view to improving uptake. And in fact, the uptake didn't get improved. And we even then tried to do the snapshot audits when consultants only had to report on one case, and we were still getting 24, 25, 27% buy-in from the consultants, so it doesn't work. And it was quite clear that the only thing that would work for data collection, so that it would be useful, if it was compulsory. Now, this isn't compulsory and nothing's set in stone, except radical prostatectomy data is going to be published in 2015, and so it is kind of compulsory, because if you don't join in, you're going to be nowhere. If you look at the 2012 data set, it is extraordinary that the median number of cases reported is 9. There's only 10 consultants reported in the country doing more than 50 radical prostatectomies. I don't believe for a second there is a urologist in this room that would go and have a radical prostatectomy from anyone that was doing less than 50 radical prostatectomies a year. And the other thing, this data is incomplete. I mean, how much can we extrapolate from it? I mean, it's quite interesting. This month in European Urology, there's a review by Vickers looking on the relationship between surgeon volume and outcome. And it's amazing, it's an old statistic, but it stands true, and it's amazing how similar it is to us, that in the state of New York, 80% of surgeons are doing less than 10 radical prostatectomies a year, and only 10% of surgeons are doing more than 50 radical prostatectomies a year. So it's extraordinary how similar it is to our data. Extraordinary. So the next thing to show you is we've put together this data set, and these sheets are available from Patricia for those that are interested. And we haven't changed it much, but in the operative part of the data set and the follow-up, we've removed continence and potency because, to be honest, it's a waste of time. There's no way to record that. Caroline's going to talk a little bit about PROMs, and I think when it comes to outcome, the only way that it's going to have to be very valid, it's going to have to be fair, because if we are going to be compared like with like, and this is collection of information for improvement, we want the awesome outlier to help the body of the urologist doing operations to feed in, and we want to improve together, and so if we're going to do that, the data's got to be good. And we don't have to do that immediately. If you look at the relationship between volume and outcome, all we have to get right first up is just the numbers. So there's enough data out there to show that just numbers is enough. The other simple things that we could do is simply length of stay. Length of stay is a surrogate for complications. We can get length of stay. We'd have to access HES, and we'd have to trust the HES data, and the coding have to be right at home. And so you'd have to make sure your house was in order at home, so your coding was right. But those are two very fair and very solid and non-arguable things. The next thing is pathology. The problem about pathology is case mix, and so everyone would immediately get very excited because, especially if we're going to be compared with other countries with higher screening, or north versus south, London versus not, private cases versus non-private cases, the case mix. But you can get. I personally think that T2 positive margin rates are a very fair comparator between surgeons. You either go in the prostate or you don't. That's a definition of a T2 margin. Sure, if you've got high volume disease, your chances of having a positive cancer margin is higher than if it's not. It's difficult to do. But it is going to be here. If you pick up one of these from Patricia, and anyone wants to give any feedback, I can be emailed, or I can contact you through the BOUS office, and we will put your comments to the committee. But we put quite a lot of work into this. It is simple. We did think of actually dropping the follow-up section altogether, but the audit committee were keen that we didn't. But I think follow-up is going to change, because we're going to have a patient-recorded outcome, and that'll be our follow-up. And because what matters is that the patients do well, they're happy, there's no regret, they're continent, they're potent, they don't have complications, and that we're curing their cancer. And that can be done as a single hit from a patient-reported outcome. So just some thoughts, but go back, work out how you're going to do it, appoint someone, identify someone, delegate the task to someone, but make sure all your cases get in. Because it's going to reflect on you and your institution, and ultimately it's going to reflect on whether you carry on doing radical prostatectomy, because this will get picked up on, and it will change. There'll be no forcing, it's going to be voluntary, but this is going to change practice, and it's going to be massive, I think.